Again, here stars. We have Chloe from our chemistry club to introduce our speaker and get started.
Hi, everyone. Thank you for coming today. I'm Chloe West. I'm the Vice President of the Chemistry Club. If you're interested, our next meeting is December 5th at 12:15 in Bradley 207. Is that right? Okay. And I'm honored to be introducing today's speaker. She is South Carolina State epidemiologist and the director of the Bureau of Communicable Disease Prevention and Control. She will share with us her insights on applied epidemiology. So please give a warm USC welcome to Dr. Linda Bell.
I know this is being recorded. Is this where you want me?
Yes, in front of that phone. Just give me a big angle.
A little unnerving, but that's okay. Well, good afternoon, everybody. I appreciate this invitation by your faculty members. And I did not have a prepared PowerPoint presentation. I just thought that it would be best if this was more informal to give you all an opportunity to ask you any questions that you might have about public health, about epidemiology. So I'm just going to touch on a few highlights, talking briefly about my own career path that led me into public health. And then I'll tell you a little bit about what I do in public health practice, more specifically for applied epidemiology in communicable disease control. So first, I will share with you that when I look at you, where you are now in your lives, and I sort of think back when I was at this stage, I actually started in college with the desire to be a marine biologist. And after a short time, when I found out that the career plan, that the market for marine biologists at that time was not great, pretty quickly switched my major to molecular biology. And that's what I ended up getting my degree in. And I wanted to take an academic path. I worked attended the UT Austin. I'm from Texas. I worked in the zoology department as an embryologist, studying what we were funded. I was in research. Our lab was funded by the Muscular Dystrophy Foundation, and we were looking at muscle cell development. And the plan for this is that this kind of bench research would translate into finding a cure for muscular dystrophy. But what we studied was muscle cell development. Our particular organism these are called marine annelids. They're sea worms. And I spent all of my time sort of looking under the microscope, tagging messenger RNA, looking at how it migrated in the embryos of these cells. And learned pretty quickly that was probably not for me. The research track, I very much respected the people in the lab that I worked with, but for me personally, I didn't love working in that lab. And I was not particularly excited about the career path that I was pretty much set on. And so I was a little bit stuck. What am I going to do with these plans? And through a chance encounter of a good friend of mine who was a year ahead of me in college, who had come back from the medical school in Dallas back to UT Austin to recruit African-American students to go to medical school. And we happened to run into each other on campus, and he says, Linda, what are you doing? And I told him, and I'm not exactly happy. He said, you know what? We took all the same classes. Why don't you apply to medical school? So this was never in my mind, no physicians in my family, had never thought of medicine. I thought, why not? I'll just apply to medical school, having really no idea, no path what it was about. So fast forward to when I was in medical school, I decided I wanted to be a pediatrician. And my first rotation, we do month-long rotations, going through the different subspecialties or whatever. And the first rotation that I had in pediatrics was on the oncology ward, pediatric patients with cancer. And I'm told by our fellow that was probably one of the worst months. It was in his professional experience with the worst outcomes that these children were having. Generally children can do very well with cancer, but these children, we were having so many complications. We were experiencing unexpected deaths and all sorts of things just in that month. And I realized that I liked children. I liked children who were well, and it was sort of heart-wrenching, the idea that I would be taking care of children who would be that ill and were dying. So I had another change in my career path. I went into internal medicine and had the plan to be an infectious disease specialist. I had an ID professor who was a sort of mentor to me, who told me that I would get much more out of my infectious disease practice if I understood public health and how disease effects impact populations. And he encouraged me to apply for a program at the Centers for Disease Control and Prevention. So throughout my career path, there are these little twists and turns. And I tell you this story just to tell you that some of you at where you are at your stage in life some of you may have your die cast and know what you're going to do. Some of you may have uncertainties, but you have to have experiences. You have to be exposed to different things to learn what you do like and what you don't like. And so certain of my life's experiences showed me what I did not feel I was particularly well suited for, did not feel I would be happy as a career path. So I went to the CDC and changed my plans to go back and do an ID fellowship. I decided to stay in public health. And as an internist, I will say that the difference between when people ask me what kind of a doctor you are now, and I say I'm the kind of doctor that goes to a lot of meetings. I'm not at the bedside. I am not involved in direct patient care in clinical practice. However, I do provide clinical guidance and consultations to healthcare providers, to healthcare facilities, to businesses, to the general public, making recommendations about how medicine and public health intersect. It's just that my patient is the population. In epidemiology, we look at how disease effects or health effects, whether they're positive or negative, affect populations of people. And so some of you may know that epidemiologists came to some prominence during the COVID pandemic. I would say prior to that, most people didn't know what an epidemiologist was unless you were at a school of public health or you were already practicing in that field. And so in one way, I was pleased to see that there was so much interest in epidemiology. In fact, we saw lots of high school level people, college level people who became very interested in epidemiology. And so let me tell you just a little bit about epidemiology. I consider myself to be an applied epidemiologist. Now, there are epidemiologists who are in academia, who do research. We have a very strong partnership with the USC Columbia campus, with the USC School of Public Health. And for one example, there's a group there that works on a big data lake. They look at interrelational databases, and they link databases that previously had been for just sort of siloed, independent surveillance systems. But this big data group at USC is looking at how to pull together data from these different sources and look at relationships and outcomes. And the one example that I'll give you of this is that we have a very strong surveillance system for people who are infected with HIV. And then we were looking at COVID. So this big data group wanted to look at what unexpected relationships might there be between people who are HIV infected and their risk for COVID, their risk for complications and things like that. So looking at a subpopulation of people with an underlying health problem who may encounter an acute health problem. And actually, before I go on, I just want to say to you all, if any questions come to your mind, if there's anything that you want to ask me, just feel free to stop me at any time, because really this is, I hope that you get the most out of this by bringing up something that you might be curious about or that you might be interested in. So please stop me at any time. But let me tell you a little bit about what I'm currently doing at DHEC, the South Carolina Department of Health and Environmental Control. I'm the director, in addition to being the state epidemiologist, I'm the director of DHEC's Bureau of Communicable Disease Prevention and Control. So I have spent most of my public health career in some way or another related to the surveillance for, the prevention of, the investigation of, and the control of communicable diseases. And so there are 5 divisions in the Bureau for which I have oversight. There are about probably 170 people in this division, in my Bureau rather. And in 5 divisions, there is the division of STDs, HIV, and viral hepatitis. There's immunizations. There is tuberculosis control. There's surveillance assessment and evaluation, which is sort of a data arm to the STD HIV division. And then the sort of wastebasket of all other conditions is the division of acute disease epidemiology. And in each of those divisions, we have surveillance systems set up. In South Carolina, and in fact, in all public health authorities throughout this country, there are laws that require healthcare providers and laboratories to report certain conditions to the health department that allow us to do surveillance. Because if they didn't report these conditions to us, we wouldn't be able to monitor how these particular diseases affect populations. So by law, they send us this data. We house it in databases. We monitor trends for this data. We generate reports because one of the key principles of surveillance is that you communicate what you find for different reasons. We can do research. We can inform the public about endemic diseases, just what underlying threats are. We can detect flags when there are unexpected increases in certain diseases that lead us to say, what's going on there? What do we need to do to study that, to control that, and or perhaps learn more to prevent future instances of these disease outbreaks? Yes, sir.
Have you ever seen the movie Agent?
Yes.
Did you ever like go around places like that?
Did I ever go around places like that? So actually, thank you for that. I was going to highlight some of the investigations that I have participated in. COVID. Next. I will say that when I was at the CDC, I was in a program it was called the EIS program. I was an Epidemic Intelligence Service officer with the Centers for Disease Prevention and Control. And during that experience, I had an opportunity to investigate an outbreak of Lassa fever in Nigeria. Now, Lassa fever is caused by a virus. It causes a viral hemorrhagic fever. It's actually of a different viral class, but the clinical consequences are related to Ebola. In other words, it's a viral hemorrhagic fever, which affects your organ systems, that leads to easy bleeding, organ system failure, so people can basically bleed out. So I did participate in an investigation of Lassa fever, and I think the movie Contagion was kind of like a dramatized, something like that. So some of the other investigations that I have participated in would include something like the contamination of chicken eggs with salmonella from a chicken processing plant in South Carolina, and eggs that were distributed in a widespread area. So I bring up that example because without surveillance systems, it can be difficult to detect foodborne outbreaks when you just have individual people who will say, I ate this box lunch from Chick-fil-A, and then 6 hours later, I developed nausea and vomiting, and then over the next few days, I had a course of diarrhea or something like that. Well, when these individual cases occur, unless we have a surveillance system in place that allows us to detect if multiple people had a similar illness and they had a similar food exposure, this is how we detect foodborne outbreaks. But with this situation with eggs, if you have a food that's more widely distributed, as many food products are in the United States, they may come from, you will get your salad on your Chick-fil-A sandwich from the Valley in California or something like that. So there can be sporadic illnesses all over the country that are very difficult to detect without a sort of centralized surveillance system. So we were looking at these shell eggs, and we saw an unusual case of Salmonella enteritidis, that was sort of popping up in sporadic cases, but it's an unusual subtype of Salmonella. And so you take food histories and we say, well, what are the common food exposures that people get? And we were able to trace this back to eggs. And we were able to trace this back The Department of Agriculture and the Food and Drug Administration also have surveillance systems in place. So if something goes wrong, they can trace food products back to where they came from. And we identified this particular food processing plant, chicken processing, egg laying processing plant in South Carolina. That was the source of these salmonella eggs, a potential source. Another thing about epidemiology is we never really say with definitive results that this event caused this outcome. What we usually say is that there are causal associations and that people who were exposed to one event had a higher relative risk of having this outcome. So we talk about causal associations, but we rarely say that there's definitive proof, unless in instances where we might actually get a clinical sample from a human person and a sample from a food product or something like that. And through genetic matching, if those two isolates from food and from a human specimen match genetically, then we can say with a much higher probability that a group of people had this bacterial isolate or viral isolate, and they were exposed to something that was in, could be food, water supply, what have you. If those things match, then that gives us stronger and stronger associations that that's in fact a causal association. Before I talk a little more about communicable disease control, I also want to mention about other career paths in epidemiology. So I've mentioned that in my career, I've spent the bulk of my career in communicable disease control. But I want you all to be aware that in epidemiology, there are also epidemiologists who work at DHEC and in other areas who focus on maternal and child health. They focus on injury prevention. Someone just asked me, are we involved in outbreaks of the opioid epidemic and the increase in deaths associated with fentanyl use and things like that. And so my area is not, but in our injury prevention area, in our Bureau of Chronic Diseases, they are. And we do look at intersections of these problems. What I gave the example of is that with the opioid epidemic, we're seeing people with substance abuse disorder who are using more and more drugs, either injectable drugs or any unauthorized use of drugs like street drugs through whatever delivery mechanism. If they're snorting these or whatever, these drugs can still be contaminated with viruses. So for example, people who use cocaine are at a higher risk of developing hepatitis C because the paraphernalia that they may use when they snort these drugs or something like that and are shared can be contaminated with viruses that can affect people. So our areas intersect because when we implement prevention programs, we need to work with agencies and organizations that provide services for people with substance abuse disorder because they're more likely to get things like hepatitis A, hepatitis B, for which there are vaccines that can prevent these diseases. So if we work with these organizations, we can prevent other health consequences. And there are treatments for hepatitis C. So we work in close collaboration because we consider this to be, we actually call this, you've heard of an epidemic, we call this a syndemic. Because right now in our populations nationwide, we're experiencing the syndemic of HIV, hepatitis C, and substance use disorder. And so these are ways that epidemiologists from different programs work together. There are environmental epidemiologists. And so for those of you with an interest in chemistry, you might be interested to know that there are interactions with exposures to toxic substances in soil or in other things. I don't know how many of you have heard of the forever chemical PFAS. So there's actually a fair amount of news coverage of PFAS. I have to ask one of the professors to tell me what PFAS stands for, polyfluoroalkylated something or other. Chemistry is not my field. Although I'm married to a chemical engineer, my husband majored in chemical engineering in college, went on to become a cardiologist, but chemical engineering was his field. So that's another unusual career path. But anyway, the contamination of PFAS, they're calling these forever chemicals because these are chemicals that are now found in all sorts of plastics, and they are contaminating the environment. They turn into these microparticles, and they've looked at studies. They take clinical specimens from humans, and they find this, for lack of a better word, this toxic substance is really found in most of the body fluids of most Americans now because of this pervasive contamination with plastics that break down in the environment and are contaminating the water. They are contaminating ocean water, so therefore they contaminate sea life, which we then consume. And so it's all this ecological cycle. That's more of a biological monitoring system. That's not exactly epidemiology because we're looking at the long-term consequences of having these types of chemicals in our body. But that's not exactly the same as an epidemiologic study. It's more of a trending thing. But I will mention something else related to chemistry and other investigations that I participated in. It's probably not sure how old most of the people in the room are, but in 2005, I believe, there was a train derailment in Graniteville where there were train cars carrying liquid chlorine, pressurized liquid chlorine. They had a stopped locomotive on a track. They switched the trains incorrectly. There was a collision, and the train cars that were carrying this liquid chlorine under pressure escaped in the form of a gas, and 10 people were killed in Graniteville as a result of this train derailment, as a result of inhaling this chlorine gas. And in fact, one of these people died 3 months later from the complications of that. But we've done a longitudinal study of other people in the Graniteville community who did not succumb acutely, but who had ongoing pulmonary effects from this chlorine gas exposure from this train derailment nearly 20 years ago. And so some people do have these long-term consequences. So these are other types of, we can do studies of acute disease outbreaks. We can do longitudinal studies of chronic exposures. Some of your faculty members, we were having a little chat about healthy eating practices. And I will say that really one of the biggest areas of epidemiology now is in the area of chronic diseases, because we're looking at the impact of cardiovascular disease, high blood pressure. In South Carolina, we have some of the poorer health outcomes as compared to most other jurisdictions in the country related to chronic diseases. We're currently having an epidemic of obesity that has been an increasing trend over the past decade or so, starting more so early in life. Obesity is type 2 diabetes is a complication of being obese. And what epidemiologists in chronic diseases are finding is that younger children, type 2 diabetes used to be a disease of adults. It was the other name for that was adult onset diabetes. Well, we see more and more children now with type 2 diabetes at a young age because of mostly these are lifestyle decisions that lead into things like obesity, high blood pressure. So it's diet, lack of exercise. We have more sedentary lifestyles and things like that. So they study the behaviors of people who have poor chronic disease outcomes. And then they look at the things that we can do to change those outcomes. We're looking at what we can do in South Carolina to change some of these poor outcomes that we see in our population as compared to other jurisdictions. So those, I think I'm going to stop here for a minute or so. Those are just some examples of applied epidemiology as opposed to an academic or research track, but there are certainly career paths there. There are career paths in applied epidemiology. In industry, they use epidemiologists for product design and things like that, for safety. They do studies about what causes injuries and they redesign products. So as an applied epidemiologist, I'm not a data manager. I don't do data analytics, but I interpret, I request study designs. I interpret that that information for various audiences. And so I think the last thing that I'll end on here is really in public health is the importance of communication. Because we collect all this data, but unless we use the data to inform the public, different audiences, I've given some examples of different risk populations, and we have to tailor our information for these different populations at risk in a way that the different audiences can understand. I do everything talks for small groups in churches to just all sorts of things. The media, this is how, epidemiology came, I think, to a lot of prominence because during the COVID pandemic, the media was sort of all over what's going on, and we were called to respond to those requests. So to keep the public informed and to make recommendations about what we could do to prevent that. And those recommendations are not always followed. I'll give you one more example, and then I will end and offer for questions. COVID was not the first pandemic that we've experienced in my public health career. We've had a few others. The other notable one was that in 2009, we had the emergence of a new flu virus, H1N1. And it took a while for us to develop a vaccine that was well matched against the H1N1 strain. And when that vaccine became available, people were clamoring to get it. We had limited supplies and we had to do allocations to certain populations to make sure that people got just a little bit until supply increased. Well, during the COVID pandemic, we amazingly actually developed a vaccine much more quickly to an entirely new virus. But what did not exist during the 2009 H1N1 pandemic was social media. So during the time of the H1N1 pandemic, people got their information from authoritative sources. We used evidence-based guidance from peer-reviewed journals. People followed the recommendations from the Centers for Disease Control, the FDA, and so forth. And so there were not really any other inroads to experts besides through the scientific community. Well, during COVID, the role that social media played really significantly hampered our ability to communicate and use evidence-based guidance to diminish the impact that COVID had on our populations, because any and everybody can put something on social media, present themselves as an expert, doesn't go through any sort of peer review, doesn't have any scientific rigor, and could just say something on social media that people would believe, or that could discount policies and things like that. And so in previous pandemics, we didn't have to combat against this parallel sort of unscientific course, this stream of information that was being fed to people about what they should do or what they should avoid or what the vaccine was doing to people. And so that was the most significant problem, I think, with that hampered our response in public health. We could have done a great deal more to prevent the impact that COVID had on our population had we had a way to control myths, misinformation, unauthorized, whatever, bad information on social media. So I will end now saying, as scientists, as future scientists, in your careers, be credible, observe scientific rigor, understand the importance of evidence, of well-designed research studies, and you have multiple career paths to choose from. And it's just that in your career paths, just have high integrity, and those are many ways that you can be successful in your scientific career. So I will stop there and see if anybody has any questions that they'd like me to entertain, or your faculty members like me to touch on anything.
I just have a quick question. So in recent years, I've encountered more people and more families who have opted out of the ordinary childhood vaccinations against preventable diseases. Are you seeing, from your perspective, an increase in the number of people opting out, or a decrease in the percent of the population that are receiving immunizations?
We are, and I'm really glad that you brought that up. It was actually in my notes. I meant to touch on this because the the push against COVID vaccines has actually bled into our ability to control all other vaccine preventable diseases, because people are really pushing back on vaccinations and more in general. Several years ago, the Centers for Disease Prevention and Control, the CDC, published a series of articles about the 10 greatest public health achievements. And immunizations in the 20th century was one of the 10 greatest public health achievements because it eliminated so many diseases, not eliminated, controlled. We have had the ability to eradicate smallpox, to eliminate measles in the United States. And we have, through vaccines, kept many threatening diseases at such a low level that people no longer believe they're a threat. Because we don't see tetanus, diphtheria, we rarely see measles, we occasionally see polio. Many of these diseases continue to occur internationally. And so when we get pushback against vaccinations in this country, and we're seeing this when we do epidemiologic studies and look at our surveillance data, there are actually pockets of populations in South Carolina that we know to be at higher risk of disease and in particular, Spartanburg and Greenville County have more resistance to vaccines than do other counties. It's also in the counties where we see the more resurgence of vaccine preventable diseases like clusters of varicella or chickenpox. We saw our first cases of measles in South Carolina in the upstate in probably more than 12 years. And these are all in under-vaccinated populations. So as our vaccination rates go down, our risk for vaccine preventable diseases goes up, particularly the risk of importations of these vaccine preventable diseases. When they occur anywhere else internationally, just through an international plane ride is how disease outbreaks occur. And we've seen this. We've seen disease importations, especially large outbreaks of measles in other communities. So I'm really glad that you brought that up, because our immunization rates in children have fallen to probably the lowest level since I've been with DHEC in 30 years.
Around what percent of children are receiving their vaccinations today?
So it varies, but I would say, because there's a whole panel of vaccines, there's probably about, so just say that there's like 13 or 14 or 16 of them. And if we wanted to get our childhood vaccination rates above 80% in many populations, we sort of teeter around there. Now, these different diseases have different communicability. So COVID is not as contagious as is measles. Measles is one of the most highly contagious diseases. And the example of that is that if we're in a room like this, and somebody in here has measles, and somebody else is not vaccinated, not only does the measles virus have a way of finding every susceptible person, it's one of the few diseases where after the infectious person leaves the room remains contaminated. The room remains infectious for up to 1 to 2 hours after that person leaves. So that virus is floating around in there, so that anybody that comes in the room afterwards may likely be infected. Most other respiratory diseases don't behave like that. But, and I'll see your question. So the point about measles vaccination is that to be effective to prevent measles, we need a coverage rate of over 95% for the measles vaccine to prevent spread, whereas in other diseases like tetanus or pertussis, something like 80% coverage is more effective in controlling disease. It has to do with how transmissible that disease is. And you had a question?
Is there any correlation in the populations of people that aren't getting vaccinated or socioeconomic status?
Is there any correlation between people who are getting vaccinated and what?
Who aren't getting vaccinated and their socioeconomic status?
Yes. So the question is there a correlation between people who aren't getting vaccinated and their socioeconomic status? And there is, because getting vaccinated has to do with having access to care. So people who are unable to get access to care, people who are of a lower socioeconomic status who are unable to take leave from work to get their children vaccinated. If there is a lack of insurance coverage, they may opt to say, I can buy food for my family, I can get vaccinated, I pick food. So socioeconomic factors do have a strong correlation with health outcomes. whether it's vaccine preventable diseases or, other people who have poor outcomes, who have a lower life expectancy and things like that. So socioeconomic status is an important question. But I will mention that the federal government has a program for children, the Vaccines for Children program, to make sure that children who are uninsured or underinsured are provided childhood vaccinations at no cost, so that we keep that subset of the population of children covered. There's not a similar program like that for adults, however. So if you don't have health insurance, you may not be able to get vaccinated. Or many health plans, you can have insurance, but they may not cover vaccines. So these are very helpful questions.
I know you had mentioned you were in zoology. Is there anything you learned while in zoology that helps you out while
So the question is, if there was anything that I learned in zoology or embryology that helped me out in epidemiology. And while I can't come up with a specific example, what I will say is that what that experience taught me is the idea of biological plausibility. So in some instances, we have had reports of cancer clusters in certain communities. And so people will report that we think that there's a higher incidence of cancer in our community. And when you do these investigations, you might look and you'll say, well, this person has lung cancer, this person has cervical cancer, this person has leukemia, this person, there are all sorts of different cancers. And so from the perspective of biological plausibility, it might be unlikely from a developmental standpoint that a single exposure would cause all these different kinds of cancers. So that would be an example of something that's a true unrelated. And so what I'll say is that, my experience in developmental biology and whatnot just taught me a little bit about biological plausibility. So when people make claims that says, well, I know we have higher cancer rates, but until you study that and you look at what the particular contaminants in a community might occur, then, and this is another issue with socioeconomic status, because they may build low-income housing in the backyard of industrial waste areas. And so that people through environmental equity, people of lower socioeconomic status are more likely to have exposures to toxins and things like that than are people who live in really nice neighborhoods at times. So I hope that's like a valid example.
Yes. I want to send a message from our dean of our campus who couldn't be here because we had COVID.
Oh, dear.
But we want to thank you for your calm and balanced approach and the guidance and leadership throughout the pandemic. And he has one question. I'll be real quick. That what are your thoughts on splitting SCDHAC as this has been discussed in the recent years?
Sure. Effective in July of 2024, they will be splitting the Department of Health and Environmental Control into two new agencies. In South Carolina, we have a few agencies in the country where health and environment are combined. I had concerns about that split because as some of the examples that I've given, that your environment is so related to health outcomes, and that what I know from my counterparts, other state epidemiologists, out there are only 50 of us. There's only 50 state epidemiologists in the country, one per state, and some in the other jurisdictions, that they really think that we're in a good position because we don't have to work across agencies when we do investigations that involve an environmental issue, a food exposure, air, water. We're all in the same agency. So what we're looking at now is the likelihood that we will have to begin working across agencies. Now, one benefit that we might see is they may be combining health agencies under what will become the Department of Public Health and the Department of Mental Health. I think the impacts of mental health on physical health and things like that have been under-recognized and are getting more and more prominence. It's important for us in public health to better recognize mental health. With the Department of Alcohol and Other Substance Abuse, we can hopefully address substance abuse disorders. So I can only look at this in the potential positive light that some good will come out of this. Restructuring is going to be complicated, and we're going to have to figure out how these new agencies will continue to work together. So and I will say right now, we are actually planning in DHEC this smooth transition plan as we can to make the best for protecting the public health in South Carolina. So I really appreciate your attention, your great questions. Thank you so much for the invitation.
Thank you, guys. We'll end the meeting here.
Thank you.